An electrocardiogram, short ECG, is a diagnostic tool that records the electrical activity of the heart. Any metabolic tissue alteration due to many different pathologies reflects on cardiac electrical activity and thus on ECG. This is why ECG remains a fundamental tool in cardiac disease detection. To perform an ECG, electrodes are attached to the skin of a patient. The electrical data collected from the electrodes is transmitted to an ECG device, which processes and displays it as waveforms. These waveforms represent the heart's electrical activity over time, meaning they reflect the sum of millions of action potentials. The vertical axis shows the electric potential, voltage, in millivolts, and the horizontal axis shows time in milliseconds. The ECG graph is typically divided into segments, with each section representing different processes in the cardiac cycle. In some segments, the line shows an upward deviation, while in others, it shows a downward deviation. There are also flat sections on the graph. To create a very basic ECG, attaching only 2 electrodes to the patient would be enough, forming a negative and a positive pole. The ECG machine uses the negative electrode as the reference point or baseline. As the electrical wave moves toward the positive electrode, an upward deflection is seen on the graph. This is the depolarization phase of the cardiac electrical cycle. Let's have a closer look at the heart muscle cells to understand how the electric signals travel. When cells are at rest, they are negatively charged compared to the slightly positive outside environment. Cells with different electrical charges are shown in different colors. As the depolarization progresses, the cells become positively charged, while a slightly negative charge is formed on the outside. If we pause the depolarization process as it travels through the cells, we will observe that half of the cells are positively charged or depolarized while the other half are negatively charged or at rest. This creates a dipole, which can be represented by an arrow pointing from the negative to the positive charge. It is important to note that ECG records the charges outside the cells. When the dipole points towards the positive electrode, the ECG tracing shows a deflection which, by convention, is positive. The larger the dipole, the larger the deflection. Later on, a wave of repolarization goes through, where the vector dipole faces the opposite direction, which leads to a negative deflection on the graph. Each phase of the cardiac cycle shows specific characteristics on the ECG graph as the electric signals travel through the heart. Let's have a look at the deflections on the graph and which part of the cardiac cycle they correspond to. When the atria are filled with blood, the SA node triggers electrical signals that propagate through the atria, causing depolarization. This is shown as the P wave on the ECG. Atrial contraction, also known as atrial systole, begins approximately 100 milliseconds after the onset of the P wave. The PR interval is measured from the beginning of the P wave to the beginning of the QRS complex. The flat section between P wave and Q wave corresponds to the duration of signal transmission through the AV node. The QRS complex on an ECG indicates ventricular depolarization. In a standard lead 2, the Q wave denotes depolarization of the interventricular septum, whereas the R wave is a result of the depolarization of the main mass of the ventricles. During the S wave, the depolarization of the ventricles of the heart is completed. During the ST segment, the myocardial action potential remains in a plateau phase, which corresponds to the time when the ventricles contract and push blood out of the heart, the so-called systole. The T wave represents ventricular repolarization, which occurs immediately before ventricular relaxation or ventricular diastole. The cycle repeats itself with every heartbeat. By using just 2 electrodes, we can only look at one single direction of the voltage through the heart. However, to acquire a more comprehensive understanding of a patient's heart condition, additional views referred to as leads are required. In a standard ECG, there are 10 electrodes, 4 limb electrodes located on the left arm, left leg, and right leg, and 6 precordial electrodes, V1 through V6, that wrap around the chest. The right leg electrode typically serves as a neutral lead. let's have a look at the leads that are formed by these 10 electrodes. There are 3 bipolar limb leads recorded, using 2 electrodes each. Lead 1 represents the voltage differential between the right arm as the negative pole and the left arm as the positive pole. Lead 2 uses the right arm as negative and the left leg as positive pole. Lead 3 uses the left arm as negative and left leg as positive pole. In the coronal plane, the unipolar leads, called augmented vector right, AVR, augmented vector left, AVL, and augmented vector foot, AVF, are formed. The augmented limb leads use one limb electrode as the positive pole and take the average of inputs from the 2 other limb electrodes as the zero reference. AVR, AVL, and AVF each detect any positive deflection coming towards them. V1 through V6 align in the heart's transverse, or horizontal plane. Each electrode is designed to detect any wave of positive charge coming towards them, making them, by convention, positive. These are collectively referred to as precordial leads. Thus, in total, there are 6 limb leads and 6 chest leads, resulting in a 12-lead ECG. The 12 leads of the ECG represent 12 electrical views on a heart from 12 different angles. By means of that, abnormalities in the cardiac activity can be precisely localized. Conducting an ECG is a standard procedure for any cardiac assessment and is indispensable in the medical field.